I'm really honored to be, I don't know if Kamal is here, but thank you so much for, this is the second time for me here in, if you can fix it, meanwhile, I would love it. It's really a pleasure and an honor. I had the first presentation I had yesterday was, I was really happy because I realized that there is a great interaction. I don't see any difference between local oncologists and my oncologists in my hospital. We are facing the same problems. It's not only a problem of costs. We have the same patients, so the feeling is exactly the same. When I received the title of this presentation, I was really intrigued. I was really, somehow I said, what can I say about that? Because the presentation is about how affordable is immunotherapy in this part of the world. You know that, can we do that? Whatever it is, I start. You see that I kept the title that they gave me originally, which is even more intriguing. You see how it's a worth to treat patients with immunotherapy in advanced GI cancers. How much does it cost? Is cost effective? What patient really deserve? You give me 3 minutes more for this. What patient deserves to be treated with a high costly drug like immunotherapy? These are my disclosures. In my country, it's mandatory to show this picture. But what is the background of this? So in the last decades, immunotherapy became one of the standards with the immunocheckpoint inhibitors in GI cancers. Not only in GI cancer, you have heard about renal, lung cancer, and melanoma, but also in GI cancers. And we have 3 or 4 different drugs in every tumor types. Like in colon cancer, we have already 2 approved, and another one is arriving. And in any setting, like neoadjuvant, adjuvant, and metastatic. So it's a huge number of patients that can potentially be treated with immunotherapy. This, as you all know, is a category of high-cost drugs, and for low and mid-income countries, I don't think that it's only in this part of the world, lower-income countries, because also next to Europe, we have many countries, all the Balkan countries, or Northern Africa, where this cannot be affordable by the society, by the health system, not even in private, because many patients, they cannot afford, even in private, the cost of the drug. And you see here from this table, that unfortunately you don't see very well, but I can show you. We have many, starting from 2021, 2020, we have several options, treatment options for any tumors. Here in the bottom, you see the most frequent situation with renal, lung cancer, and melanoma. But in red, you see the GI tumors. And the GI tumors, this is 2021, but if we arrive in 2024, we have, this table became very crowded. So we have many treatment options if you consider also hepatobiliary cancer and HCC, not so much pancreatic cancer as we will see. Unfortunately, what happens in the last few years, since 2020, where the first immunocheckpoint inhibitors has been introduced in the market, which was nivolumab at the beginning and then pembrolizumab, the cost of the drug didn't reduce, company didn't cut the cost. If you look at these 4 years, the 2 couples that are pembrolizumab and nivolumab that's been approved in many tumor types, let's say 6 or 7 if I remember well. Starting from 2016 until now, so 5 years ago, we had a cost reduction only 0.7%. This is not justified. I will be a little provocative against pharma company and regulation authorities. We have to work on that, which is one of the most important points. So, in my analysis, I'm really sorry you're not able to read all the slide. I review a certain number of public studies, which like the 12 or 13, with drug accepted by the EMA, by the FDA, and we did a data extraction of overall survival, progression-free survival, and we wanted to check the real benefit, which means the delta. I will show you for every study the delta of overall survival, the delta of progression-free survival, and another concept that is not very common for us medical oncologists, which is the number needed to treat. What is the number needed to treat a patient? It is the number of patients where needed to overcome and other causes of death, other problems from other diseases. So in this case, the percentage and the benefit is a solid number. It's not altered by other factors. In these two tables, if you are able to read it, I put all the studies, but for some of them I will go into details, where immunotherapy has been approved in GI cancer. So you will see there are three colorectal cancer. One is second line with nivolumab, ipilimumab, and the other two are first line, always nivolumab or pembrolizumab. Then we have 2 biliary tract cancer. We have esophageal, three or four esophageal cancer. One is adenocarcinoma, the other one is adjuvant. And the other 3 are metastatic disease in adenocarcinoma, 2 gastric cancer, and then we had 2 hepatocellular carcinoma, HCC, which is important also in this part of the world. We evaluated the delta of the overall survival and the delta of progression-free survival in almost all the studies, but not all the studies were presented in the right way, and the publication is a little complicated to interpret. By the way, I wanted to go into details in some of these studies that I showed you before, and I want to try to demonstrate at the end of this presentation if we have some factors like, for instance, clinical features or biomarker that can be used to select patients that they really deserve to be treated with a highly cost, with a drug with a high cost. So in colorectal cancer, we had 3 different studies. The most important is this, is the Keynote 177. It's a first-line chemotherapy with first-line pembrolizumab versus chemotherapy standard. And we have finally biomarker here. You see the biomarker in this case is MSI, or mismatch repair deficiency. What is the delta of this study? This number is important, is huge, is impressive. 40 months of benefit. So for MSI high patient, or let's say mismatch repair deficient patient, we have a very, very important improvement in overall survival and in PFS, if you can see here. And this is probably the category the most, that benefit the most from immunotherapy. We will see later this number. You won't see this number in any of the other tumor types that I put here as example. So this is indicated in Italy. We do it for several years now. So the first thing we do when we have a patient with metastatic colorectal cancer is to test MSI. Yesterday I heard that you do also here. But MSI for us is the basic driver for the beginning of the journey of the patient in a metastatic setting. Because if the patient has MSI high, it has to be treated with immunotherapy. This is the real category where I can spend maybe 50,000 per month. This is my first assessment. In esophageal gastric junction, the situation is a little different, but you will see it's still interesting because we have the checkmate 577 with adjuvant nivolumab. This is an adjuvant study, but the drug will be approved. It's already been approved by FDA, the MEA. With this benefit of progression-free, the disease-free survival of 11.4 months. Of course, we don't have data on overall survival yet, but it's the first drug approved in esophageal cancer adjuvant treatment, and it's quite important. This is a very important step forward. What about metastatic disease in esophageal squamous carcinoma, which is the most frequent case? You see the delta, it's a little less here. You see 6.3 months in this case, 5.1 in this case. Always the 2 competitors, nivolumab and pembrolizumab. It reminds me when I was a resident of this fight between irinotecan and oxaliplatin. There is always a couple, one competing with the other. This is also a good result, but I would say clinical meaningful, not really as important as the MSI status. There's another drug arriving, which is tislelizumab. I talked about that yesterday with a delta of 2.3 months, but it's an interesting drug because it's a different mechanism of action compared to pembrolizumab and nivolumab. So what about gastric cancer? Also in gastric cancer, the natural history of the disease has changed dramatically in the last few years due to the introduction of immunotherapy. And in fact, if you see here, the number is a little less, it's 3.3. You don't have to look at only the number, you have to look at the all population, the incidence and prevalence of gastric cancer. 3.3 months in all the natural history of the disease is a lot, but this is a little complicated, the story, because we have a biomarker here, which is PD-L1 CPS more than 5 for nivolumab, and we have another biomarker here for pembrolizumab. These two studies are somehow mirrored, which is CPS, PD-L1 CPS more than 1. However, the higher is the CPS of the gastric cancer tumor, the highest is the efficacy. Because if you look at the data of pembrolizumab here, when the CPS is more than 10, and it's not only more than 1, the benefit is much higher. The hazard ratio goes down to 0.64. So this is another indication that is not based on strong level of evidence. Should I treat a gastric cancer patient only with CPS more than 1? I would be very cautious to spend money, I would say. In this case, if it's more than 10, of course, the patient deserves to be treated with pembrolizumab. What about biliary tract cancer? Biliary tract cancer, you know, it's a very chemo-resistant disease. We don't have so many options. We only have gemcitabine, nab-paclitaxel, and so on. However, there is an interesting study with durvalumab that you see here. But look at this number. It's not comparable with the 40 months we had with MSI-high colorectal cancer. It's 1.6. 1.6 of delta overall survival and 1.5 of progression-free survival. We have no biomarker, unfortunately. So we have no PD-L1, we have no MSI. So we treat all patient population with durvalumab plus gemcitabine and nab-paclitaxel. Is this justified? Let's see. Maybe, in my opinion, yes, but it's a little complicated in a world where you cannot afford this huge amount of expenses for a single patient. Same story for pembrolizumab. You see, same numbers, exactly the same, no biomarker. What about hepatocellular carcinoma? We have 2 studies, IMbrave with atezolizumab plus bevacizumab, no biomarker at all. A little better than the biliary tract cancer, 5.8 months. In this case, is significant because what you want to do for HCC, you only have sorafenib, and overall survival is really disappointing. Also Himalaya, which is a little less, it's durvalumab plus tremelimumab. So let's go to the direction of give some recommendation. What criteria could be taken into consideration for specific guidelines in this part of the world, for low and mid-income countries? Let's say overall survival benefit, PFS benefit, yes. In this case, highly recommended MSI for colorectal cancer. I try to formulate a new terminology that is not really scientific, but for me, it's still clinically meaningful to treat patients with gastric and esophageal and HCC when the benefit is around 4 to 6 months, although it's not the benefit that we have in colorectal cancer for MSI-high patient. It's limited in biliary, but let's talk about that later. Based on biomarker, what we can recommend in your country, or even in Italy, don't forget that this is a costly drug also in Italy, so it's a big problem also for our society. Once again, MSI-high is recommended for all tumor types in all lines. You will see first, second, and third line. I personally recommend, based on that study, the 2 studies in gastric cancer, to treat the patient when we have a high PD-L1 CPS. Let's say more than 10, it is not, be careful, it's not based on guidelines, it's not based on level of evidence. It's just, it makes sense to have a higher, when you don't have enough money, you have to do a selection of patients. This is a good way to select some patient in gastric cancer patient. Clinically meaningful in other disease. So I'm going to the end quickly. The absence of biomarker in biliary tract cancer or hepatocellular carcinoma, is that good or is that bad? Maybe it's good also, because all the population can receive the same treatment and have a good response rate and a good prolongation of overall survival and PFS. But this is still a personalized medicine. We had the same talk many times with the anti-angiogenic drug, if you remember, with bevacizumab, ramucirumab in second line, so many stories. This is the scenario, but unfortunately, like it happens also for hepatocellular carcinoma, we don't have so many options. So it's not like colorectal cancer or gastric cancer where you can do a triplet. I will show you the triplet in a second. So in my opinion, it makes sense, but it's costly. We know that it's costly. Do we have alternatives? Yes, we have some alternatives in gastric cancer. In gastric cancer, you have a choice, also in colorectal cancer, you have a choice of the doublet or a triplet. I talked a lot about that yesterday. In some cases, even if you have a little positivity, like let's say PD-L1 from 1 to 5, you can give a triplet, which is tolerable. You can give FLOT, you can give TEX, you can give it whatever you want. And you can achieve at least the 3 months of overall survival gain that you had from immunotherapy. So in my conclusion, the immuno checkpoint inhibitors-based treatment changed dramatically the history of the disease. Unfortunately, the problem of the cost analysis effect remains. It's not solved, not even in my country, not also and not also here in the low and mid income countries. We need to identify better biomarkers. You know, when you send, I don't know, the colleague of the Lancet Oncology, when you send a paper, they always say, you don't have a biomarker. You will choose another journal. This is not, we need a biomarker. This is an official statement every time you send a registrative, the readout of a registrative study. So we have to review also all this international policy. We have to address disparities of immune checkpoint inhibitor success to warrant a global cancer equity. So just two slides, a little provocative. What are the role of international organization in this place, in this scenario? The World Health Organization during COVID-12, the COVID-19 pandemic, they were mobilizing a lot, did a lot, with a lot of energy to ensure all the treatment all over the world. Cancer is an emergency, so they have to do the same also for cancer and for new expensive drug, also here in SARC. And the market is also important, the market access. So the World Trade Organization, they have to act in this direction. And what is the role for pharma company? So we always accept funds from pharma company to organize meeting and to do, I don't know, the travel expenses and whatsoever. But they have to work in a patient program, they have to work reducing the cost of the drug, because it's not plausible to have two drugs like nivolumab and pembrolizumab that have been approved 5 or 6 years ago in, let's say, 9 or 10 different tumor types, and still the cost is so high. So bevacizumab with Roche, the cost has been cut only when there was the introduction of some kind of biosimilar. It's not the same for this because it's not the right time. We need 10 years before a biosimilar appears in the market, but they're working on that. But in my opinion, there is room for a reduction of costs, and this is quite important, not only for SARC, but also for Western world. The other, and then I finish. The other problem is, should we promote a kind of patient program? For instance, for MSI high patients, this is quite crucial. They have to do that. Like they did it in Africa and in other parts of the world for malaria, for HIV. So the benefit is so important, it's so crucial for this group of patients, they have to do it also for MSI high patients in any of the solid tumors. Just the end of my presentation. So I've heard you're working a lot on clinical guidelines. You know, clinical guidelines, they have to, usually the clinical guidelines is not only based on level of evidence, it depends on what you use, but also on a gentleman agreement between experts. So you have to consider at this point the absence of biomarker, the efficacy in a certain group of patients, and to adapt your guidelines to what we are doing in ESMO and in ASCO guidelines. You know, ESMO is a living guidelines. For those of you who were there yesterday, the living guidelines means that every month is updated. So when you have something new in terms of financial, not only on effectiveness, you have to change your guidelines, not only promote your guidelines immediately. And the guidelines for us have a legal issue. So I don't know in your country, from this point of view, because the patient that sits in front of you, he knows already how he can be treated. He has Dr. Google, if you they already know everything about you. They already know they have to be treated with pembrolizumab or with other drugs. So it's very hard to say, okay, I don't have enough money to treat you with this drug. So there's a call for action, as I told you, for policymakers to implement equitable drug pricing policy, and oncologists to advocate for essential, to push companies and regulation authorities, and for all the monetary funds in the world to improve the treatment of cancer. I see that you're doing a good job here, a great job. Yesterday I've heard about all the plan, the program you have, and really it's commendable. So I'm with you. Thank you so much.